in his or her career, but by the time you've worked up the same patient for some drug addiction related problem for the 10th time in your internship year, you're sort of discouraged about it. And so again, we're going to have a broad overview of a lot of the major issues that we need to understand if we're going to be good doctors. Uh-huh. Yeah, well, we never got in a hospital or saw a patient until we were third-year students, so you're way ahead. That's an important evolution. We're teaching medicine in an entirely different way, in part to compensate for some of the issues that we'll be examining. Now, in keeping with the goal of having a broad-based look at all of these problems, I have called on several of my colleagues, friends, patients, in different cases here to help us with this program. To my left is, far left is Mr. Jack McMeekin, or Mr. John McMeekin, I'll call him Jack, who's one of the world's special nice people. And that's not on his CV, but that is the case. And Jack went to Penn State and then got his MBA from Wharton. And then he and I went at the same time out into the real world, me and as a young doc in practice at Pennsylvania Hospital, and Jack as a person on the administrative team at Pennsylvania Hospital. And we both had the very special privilege of learning under one of the really great and famous hospital administrators in the United States, Mr. Robert Cathcart. And Jack went from Pennsylvania Hospital to the Philadelphia Health Management Corporation, which was an organization to manage federal funds that were coming into Philadelphia for health care. And the point, I want to stop at each of his stops to note that he has a very broad base in healthcare administration. I mean, he went from being a young administrator in a hospital to this financially oriented administrative control mechanism for distributing funds for medical care. Then he went next to Blue Cross, where he was senior VP in charge of provider contracting, and ultimately to become the president and CEO of the Crozer Hospital, which is near Chester, and about 10 miles from here. And he grew that into a 5-hospital system. They merged with several of the community hospitals around them and formed the Crozer Keystone Health System. And he ran that until he retired a few years ago. And he continues to be active in a consulting role and so forth in the Philadelphia area. Mrs. Gloria Hockman, sitting next to me, is a very special individual who has had a two-pronged focus to her career. She graduated from Temple with a degree in communications, and then she took later on a fellowship at the Philadelphia Center for Psychoanalysis, no less. And you'll see the influence of this in the rest of her career, which, as I said, had two main foci. First, she was heavily involved with the National Adoption Center, an organization that expands adoption opportunities for children in the United States foster health care system. And in this role, she used her expertise in family dynamics, relationships, issues stemming from divorce, mental health issues in general. And her second major focus has been medical writing, which efforts have yielded her no less than 27 awards from a host of prestigious organizations. She's written several books. One of them was on the New York Times bestseller list for some time. One was Living with Manic Depressive Illness, written with actress Patty Duke. A second about adult children of divorce. A third is entitled Cardiac Bypass Surgery, Whatever a Patient Needs to Know. And the fourth is an e-book which deals with issues faced by baby boomers. And she's written innumerable articles on a wide variety of topics which have been published in the New York Times and Philadelphia Inquirer in a host of prestigious magazines. And she's written about a broad spectrum of issues from mental health, relationships, living with Alzheimer's, plastic surgery, breast reconstruction after cancer surgery. She wrote a remarkable article about two conjoined children who are now 21 years old or 20 years old. Truly, they're joined at the head. And everything that she writes is meticulously researched and beautifully written. I've read many of her articles. But she brings a perspective on the evolving patient interests, needs, so forth. It's relatively unique, I think. On my right is Mary Jo Cimino. She's one of these very special nurses that no hospital can run effectively without. She's a 1979 graduate of Cooper's. Oops, sorry. She's a graduate of Cooper's Diploma School of Nursing, as my wife was at HUP, Hospital University's Diploma School of Nursing. We need to talk a moment about that. These women, and they were essentially all women in those days, were the best trained nurses that have ever been produced. They spent 3 years totally engrossed only in their nursing training programs. They had graduated responsibilities from the beginning. They learned how to take care of patients. This contrasts with my own daughter, who I love dearly and have highest respect for, but she went to nursing school for 11 months to Drexel's accelerated program, and you can't learn to be anything like this in 11 months. She learned she's smart, she learned all the facts she needed, but I said, Julia, when are you going to learn how to be a nurse? And a lot of nurses want to be educated, which is in a general way, which is wonderful. But there's something lost, and Mary Jo has that. Now, she's ridden through the ranks here at Cooper in the cardiology and critical care area, and she's now the clinical director of adult critical care for the whole hospital. She's won 2 very nice awards for her nursing excellence. She's published articles on red blood cell transfusion and implementation of hypothermia in patients in the critical care unit. And she's presented in a number of forums on patient safety and evidence-based practice, so forth. But the most important accolade I can pay to her is that if I got sick, I want Mary Jo to be part of the healthcare team taking care of me. All right, and to my right is my good friend Dan Hyman. Dan is head of the Division of General Internal Medicine and Primary Care. Dan is a graduate of Philadelphia College of Pharmacy, graduated cum laude from there. Chose to go to the Osteopathic School of Medicine in Philadelphia because of the role modeling influence of his family doctor. After graduating from PCOM, he did his postgraduate training in internal medicine at Cooper. He's been a faculty member for the past 17 years, and he runs a wonderful practice in neighboring Gloucester City. He's a fine physician in every sense of that word. He's a doctor's doctor, which is the ultimate compliment for a physician. He'd be my doctor, except his office inconveniently located. But I did send my son to him. He's a fine teacher. He's won no less than 13 different teaching awards to date. I'm sure there'll be many more. We're very fortunate to have him as a faculty member. So we have a broad-based panel, and let's get into our subject. 50 years now is going to be our the period that I have been practicing fundamentally, the period we're going to look at. I have compiled a list of how patients have changed in this 50 years, which we'll hand out in a minute. The bottom line, though, again, is to take these observations and see what we need, so we know what we need to do to satisfy the patient of today. If we don't do this, we're not going to meet their needs. Okay, so why don't we, Dan, could you, or somebody, maybe two of you could just. Yeah. We're going to start with Mrs. Hockman, who's going to talk about her observations.
Thank you for having me here today, Dr. Viner. It's a treat for me to be able to talk to all of you who are the doctors of tomorrow and tell you what I've learned in the years that I've been doing medical writing.
You need more?
Is there 50?
Yeah.
I'll wait until these get handed
Yeah,
out,
I'm
sir.
sorry, I
That's
didn't-
okay,
I
not
should have
a
handed
problem.
this out.
That's okay.
First thing, but. All right, so this is just, this is not to read or memorize. This is just to focus us.
You realize these folks expected you to email this to them?
I know.
Had it right in front of them.
On their cell phones. So, okay, well, medicine obviously has changed dramatically from the time I started to write about it. For one thing, I'm sure it's hard for you to believe, there was no internet. And so when I had to research a story, I would go to the library, and I would sit there for days, poring over records and over books and journal articles. And my special friend was the librarian at what was then the Institute of Pennsylvania Hospital, where they had all these terrific books on mental illness, which was something that I was particularly interested in. Today, not only am I more knowledgeable because the internet exists, but patients are more knowledgeable. They have access to tons of information on the internet. The downside of that is, or several downsides, but one is, it is truly the Wild West out there. As all of you know, anybody can put anything on the internet without editing, without verifying, without looking at all perspectives, which is quite different from what happens to a writer for a newspaper or a magazine. When I'm writing, at least 3 pair of eyes see my copy before it gets published and might say to me, you say, okay, 1 in 10 people in this country suffer from depression. How do you know that? Where did you get that information? Where did you get that figure? You tell me that the signs of depression are different in children from what they are in adults. Who told you that? Did you get all sides of the issue? Did you talk to kids who are going through this? What do they say about it? So it behooves me to get do as thorough a job, get as much information as I can before all these eyes get to look at it and question me. But I know that's going to happen. That is not so, obviously, with the internet. The other problem, as I see it, is that people get the information, but they don't necessarily know how to synthesize it, how to interpret it, or how to apply it to their own conditions. So that's something that I think both you as medical students and future doctors and I and my colleagues as writers have to work together to help people help patients understand what is all this stuff they're getting from the internet and how do they use it. I think sometimes patients have told me they're very confused by what they read and because they see contradictory information. And how do they interpret that? What do they do with it? So one of the things that as a medical writer, and I urge my colleagues who are medical writers to do, is to make sure that you understand perfectly what you're doing. Ask the simplest questions, or what seem to you to be the simplest questions. When I wrote about heart bypass surgery, I didn't know a vein from an artery, but I was not afraid to ask the questions that are in the minds of the readers. And one of my editors once said to me, the best person to send out to do a story is somebody who knows nothing about the subject, because they're going to ask the questions that the readers are going to ask. And that does make a difference. I think that anxiety is heightened among people because they have access to so much information. They get on the internet, they see all kinds of stuff out there, and they get anxious. Some people get obsessed. about going to the internet over and over again. They get diagnosed with a condition or they suspect that they have a condition. Pardon me, they go to the internet and they become really anxiety-ridden. Part of what I try to do as a writer is to relieve that anxiety or at least put a realistic face on it, which is something that I believe doctors also have to do. Very often, patients believe, and sometimes they do, no more than their doctors. And so they go to an office with tremendous demands. They want to be participants in their own health care, and they think they have enough information to be able to do that. So, as a writer, I feel even more responsible than I ever did, but have always felt that way, that what I say is going to make a difference. It's going to hit a nerve with people, or I hope it will, and make a difference in the way they think and act and feel and behave and live their lives. And indeed, when I wrote the book on heart bypass surgery, I remember one doctor telling me that a patient came in with my book and it was all dog-eared and pages were flipped back, and he said to this doctor, "My case is on page 272. That's me. That's me. She never interviewed me, but that's me." And this patient was kind of interesting because he came in to the doctor's office wearing a green jumpsuit. And he said, I want to have heart bypass surgery. I think I'm a candidate. I've read this book. I've read articles. I think I'm a candidate. I want you to do it. And if it's successful, then I'm going to give $10,000 a year for the rest of my life to your institution. And it happened to be Deborah Heart and Lung Center at the time. And he also said, when I'm on the table, if you say I'm not going to make it, here's a phone number. I want you to call this man and tell him what to do with my flower stalks. And he said, okay. But the man obviously survived, and he, for the first 5 years that I followed the case, he was giving $10,000 to Deborah Heart and Lung Center, which was very exciting. Technology has changed lives for all of us in every way, in every arena, and I see the way doctors communicating with their patients have changed. Some doctors will communicate through email, which is the way most of us prefer to get our information these days. Many of them will give patients their cell phone numbers. Now, I was telling a group of people yesterday that I'd be speaking with you this morning, and that I was going to say this, that doctors give cell phone numbers. And all of these people around the table that I was talking to was at a luncheon said, cell phone numbers? My doctor never gives me a cell phone number. But that is certainly happening more frequently. In waiting rooms, I have noticed that, particularly in outpatient surgery, that there will be monitors and a patient will be assigned a number. And you can follow your patient at every step of the way. And they'll say, now your number 11 is being prepared for surgery. Then you wait, number 11 will be entering surgery in 10 minutes. Number 11 is now halfway through the surgery. And you get these minute-by-minute reports. And I saw that happen to me personally with my sister was going through some outpatient surgery. And I was stunned to know that I didn't have to keep going up to the desk to ask these questions. It was on a monitor and I could see it. And it was certainly making me a happier family member by knowing what was happening to her. I think there are so many doctors now that are assigned to drugstores. I don't know how many of you have seen this, but I was in New York last weekend, and Duane Reade is a major pharmaceutical drugstore in New York, and they have a doctor on their premises. So you go into the drugstore at any time you want to, and there's always a doctor there to answer your questions. So you can't reach your doctor through your cell phone or through his cell phone or by email. You can go right into a drugstore and do it. And of course, we all know that flu shots and shingle shots are being given in drugstores. And this is a dramatic change, certainly, over the years. Are all of you familiar with ZocDoc? Anybody familiar with ZocDoc? Yeah. Okay. Well,
How do you spell that?
ZocDoc. And it allows patients to get into a doctor's appointment book and schedule a visit through the website. It's being used right now in more than 1,000 cities by doctors in 40 specialties, and it cuts out the work of having to struggle to get an appointment, and I'm going to get into that in a few minutes. There's also a piece of digital technology that I've just become familiar with. It's an app called MedCal, and it allows doctors to learn what concentration of a particular medication would be best suited to their patient. And they can do that. So if you're prescribing a medication for, say, an 18-year-old, an antidepressant, this would give you an idea of how much of that antidepressant that person should take based on his or her characteristics. Very different from what it used to be. In terms of teenagers, communicating with teenagers, whether it's about medicine or anything else, is a whole arena unto itself. And doctors are finding that it's best for them to communicate with teenagers through cell phones. So if you have a teenager who is, for example, suffering from depression, and you know that they are unlikely to take their medication on a regular basis, you can communicate with them and let them know, remind them that, did you take your medication today? It's been 6 hours now. This is the time when you should be taking it again. And that's the way teenagers are getting their information. They can also communicate with their doctors in this way, which gives them a chance to ask questions that might be otherwise embarrassing, but can do it through their cell phones. So I think that all of us have to be aware that that's how people, increasingly young people and older people too, are getting their information. Doctors have their own websites today. There was a time that probably none of you remembers when there wasn't such a thing as a website, but doctors didn't advertise in any way. Now they're promoting themselves, promoting their practices on websites. I do a lot of writing about cosmetic surgery, and there is not a day that goes by that I don't get some ad on my email from a doctor who is promoting some form of Botox or some form of fillers or some new plastic surgery that's going to make you young forever. And
Can't fool Mother Nature.
can't fool Mother Nature, but they try. They try. With an expensive plastic surgery procedure, maybe you can fool Mother Nature. I don't know. And they're finding that video links can cut down patient visits. You can communicate with patients via video, see their pictures, make a diagnosis, prescribe medication. So there's just so many changes in the offing. We've seen a lot of them and the seeds of a lot of them, but it's certainly not all evolved yet. Now, I think in spite of what I've just said, that patients are angrier today than they used to be. Doctors are no longer gods and goddesses. Patients are more questioning. Healthcare, pardon me, is more fragmented than it once was. There are so many different specialties. You can't count on your family doctor to take care of all of your needs, as I did when I was growing up. And people are confused. They don't know how to manage their own health care. You need to have a manager. You need an Ed Viner who spends time with patients, but there's not many Ed Viners left who will do that. And patients are continually frustrated because they don't have that kindly family physician that they believe in. And when you see the incidence of malpractice rising, I believe it's rising largely because that relationship is absent. People don't sue doctors that they have a good relationship with, even if they think the doctors have made a misjudgment or made a mistake or whatever. People are angry because some of them don't have insurance. And even when they do have insurance, they have to wait a long time for appointments. I recently had a situation in my own family where I believed that my husband needed a dermatologist for something that could have been serious. And I called a dermatologist that we had seen on a regular basis, and his assistant said, well, this was in August. She said, the doctor can see him in November. And I said, no, I don't think so. He needs to see him now. If this is serious, he needs to see him this week. And she said, well, I'm really sorry, but there's no appointment till November. We're just all filled up. And I said, you tell him that I called. Now, I'm able to do that because this doctor knows my name and because I have a reputation in the medical field. That should not be necessary. But she did tell him. And in a half hour, the same person called me back, and miraculously, there was an opening the next day. So patients get angry about that, having to struggle to get an appointment and wait too long for it. Once they get to offices, they get angry because they have to wait too long. One woman I talked to said, I give it 20 minutes. If a doctor can't see me in 20 minutes, I leave. I either make another appointment or I find another doctor. And once you get into the doctor's office, because of healthcare today, they might spend, if you're lucky, 10, maybe 15 minutes with a patient. And a patient doesn't feel like you're really getting to know him or her. You barely have time to take a history. So there's lots of reasons why people are angry. I think another thing that angers people, and there's been things written about that, although I haven't written about it, is that there's a tremendous amount of anxiety when waiting for test results. Somebody goes for a breast biopsy, and the doctor gets the results maybe in 3 days. A patient waits until the next appointment, which is in 3 weeks, to find out the results. It's a really anxiety-producing period for patients, and particularly with new technology. There have to be ways to let people in on their health care in a more timely way. This can be a big problem. The other major change that I've seen is that patients are much more open about their medical conditions. It used to be that they didn't really talk about serious medical conditions. The word cancer wasn't even said out loud. It was the C word, if you even said that.
That's a big C.
Big C.
It was whispered.
Whispered.
A big C.
Whispered. And not all that long ago, I did a piece for Newsweek magazine in Japan, the Japanese edition of Newsweek. And doctors there, as it turns out, didn't even want to treat patients with cancer because they felt they failed so often and they didn't want to be associated with failure. And that's in today's times. So that article was printed only in Japanese, and the only thing I could read was my own name, so I can't tell you exactly how the translation occurred, but it was a very interesting experience for me. People are chatting in chat rooms. I have a cousin who has fibromyalgia. She has a really hard time finding doctors who think this is a legitimate condition, and so she gets her information on chat rooms with other patients, and they talk about all the things that people talk about. What are your symptoms and what's helped you, and which doctors are okay and which doctors are not, and can you exercise? They tell you to exercise, but you're too tired to do it. And they get a lot of information from each other. There have always been support groups. I mean, I've always relied on support groups for patients because I believe that no matter what I'm writing, an editor once told me, I don't care if you're writing about politics or pop culture, if you're writing about food or fashion, always talk to people because people want to know about other people. And so I always include people in my articles. And I find them frequently through support groups. That's what they do. There's a bipolar support group, and there's a depression support group, and there's an Alzheimer's support group, and a heart patient support group, and a Zipper Club, and I mean all kinds of things around where patients will gather and talk to each other and offer each other support. So a friend of mine, and this I thought it was strange, but even in today's times with technology being so available, who when she was diagnosed with breast cancer, she developed a mass email list, a listserv, and she put 92 people on it. And some people were I knew just casual acquaintances of hers, and some were closer friends. And she kept them up to date periodically on where she was with this breast cancer, what stage it was in, what the test results were, her anxiety waiting for results, and she went through this entire thing for about 6 months until her case was resolved to the point where she could say, okay, this is the last email you'll be getting from me on this subject. And I thought, isn't that strange? Would I do that? Would I want 92 people to know? Would I think 92 people cared what was happening to me every step of the way? I don't know. I'm not sure how I feel about that. But it worked for her because it gave her some sense of satisfaction, which was a good thing. And certainly, people like Betty Ford and Nancy Reagan, who talked openly about their conditions, made it more okay for all of us to be able to talk about what's wrong with us and how we can get help, and people network with each other in a much more open way than they used to. So these are the major changes that I've seen in terms of my responsibility I need to work more closely with doctors. I've always worked closely with them. I think my responsibility is even greater now, and I think their responsibility is to be accessible to me so that together we can provide patients with the best information, the best care, and the best chance to be happy with the medical care they're getting. I'm very happy to answer any questions at any point that Weiner says it's okay to take them.
Well, why don't we go on and let everyone present, and then we'll, jot your questions down, and then we'll have the last 45 minutes or so will be all questions. And now, Gloria's brought up a lot of challenges for us. All of what she said has tremendous implications for us. We'll call on Dan Hyman next to tell us about what life's like in the real world. I do want to say one thing I meant to say earlier. While everything is changing, yet much remains the same. And what remains the same at the bedside or in the exam room is that the patient is worried about something, needs reassurance, needs attention. Our tools are openness and honesty, and he's supportive. And we talked when I first time I met with you. There's some healthcare people just communicate that they care somehow, and you know this immediately, and others don't. And the ones that don't need to understand that and learn how to do that better. We'll be talking more about that. But again, everything what we have to do is evolve the way we manage the situation, handle ourselves, communicate with people. It's different, but the needs and our tools remain the same. Now, a lot of what Gloria said puts a lot of pressure on you. How do you handle the instant gratification that's between the lines, the need for that that's between the lines, everything she said here?
I wish I knew. And unfortunately, many of the points Gloria brought up were very true. And when Dr. Weiner asked me to do this, I went through in my mind what I would say and what I would talk about, and I wrote it down. And then last night with the rain out, I decided I'll look at it again, and I couldn't believe how negative it was. But that's not true. It really isn't. I think many of the changes are perceived as negative, that patients are treating their physicians different, they treat healthcare differently, but I don't think it's all negative. I do think the fact that patients are informed, they can have an intelligent discussion with you, is a positive thing. It's worthwhile, but I think part of our job is not only to address this, but also to correct what is misinformation many times. So I think the fact that our patients are savvy are very important. Many of the interactions that you'll have with patients, they'll write everything down. I have patients that'll come in with 3 pages of notes to present issues to you, and then they'll take notes. But many of those notes were facts that they already know what the answer is to their questions, and they're testing you. So just realize that your test Monday is, or whenever the biochem test is not your last test that you'll get. So they do know the answers before. They all listen to Dr. Oz. They compare you to Dr. Oz. They say whether you look like Dr. Oz or not. And Dr. Oz says, write down the questions. And he believes in supplements. He believes in exercise, many of which is true, but many of which is also misinformation. So you do need to be aware of that, correct the misinformation gently, and it is a give and take. You can't, just because we are taught evidence-based medicine and we are teaching you evidence-based medicine does not mean that the patient wants to hear that. They still want their PSAs. They still want their rectal exams on a regular basis, some people 3 times a year. And it is a different interaction, and you need to get to know your patients and understand that each individual and each interaction is quite different. Patients do feel empowered nowadays. I've had people who have sent me introductory letters. I've never met them before. I just had one about 3 weeks ago. He sent me a 5-page letter. Primarily 3 of the 5 pages were about his erectile dysfunction and how he was not having any success with any of his prior physicians, and that he hoped that I would fix it. I was hesitant to call him back, but he ended up having an appointment set, and he's a very nice man and somewhat misinformed about things, and I think we're able to help him. So I've also had people who've wanted to interview me prior to me becoming their primary care physician. Generally, if patients are in managed care insurance companies, they have to name a primary care physician. So it is understandable that they want to meet their doctor before naming them because they're stuck with that physician then, although that is a bit difficult. So again, you need to juggle this. I had a woman in who was a nurse, not Mary Jo, at Cooper about 2 weeks ago, and she wanted diet pills, and she was on a number of psychiatric medicines for various issues, and I told her no. So she said, there are 2 new diet pills out, and I honestly said, what you need to do, I am not familiar with them, I don't know anything about them. And she said, go do some research and get back to me as she was walking out of the room. So you will meet them. Mary Jo and I will talk about this afterwards, all right? There's a suspicious nature sometimes that you need to carry into a room. Patients are often looking for, not often, periodically looking for secondary gain, and you need to be aware of that. And secondary gain, most commonly that we're most suspicious about is drug-seeking behavior. And part of the benefits of our information age is that there is a way to research this. And simple thing would be a phone call to your local pharmacist, which I've done many times in the past, but now there is a database in New Jersey where you can access controlled medications per patient. And as long as you're a licensed physician or nurse practitioner, and I think RN also, you can access this database and you can see patients coming in requesting refills on medications that you haven't seen before. So if they're asking for their Valium or their narcotic pain medications, you're very suspicious of that. And there are behaviors that you look for that you need to be careful with. And we have come to the point now where we cannot believe patients on a first visit, that we have to get records from their prior physicians. And those records can't be carried in by the patient because they can be doctored. So part of the deal is that the patients are informed when they make their appointment that no controlled medications will be written with the first visit, and that they sign a record release. We get their records, we review their records. They have to sign a narcotic contract, which is very controlling. But it protects you, it protects the patient. Part of a narcotic contract says that a patient will only go to one physician for their prescriptions. They'll use one pharmacy. If they miss an appointment without an excuse or a phone call, or if they take medications that are different, there's about 20 points that we have on the contract that they will be asked not to get their prescriptions from us any longer. So there is a litigious aspect to care that you need to be aware of, that you will be aware of, and you'll see this very frequently. Again, these are patients who are few and far between, but it depends where you practice, the type of practice you're in, but you will come across this. Behaviors are much more open with the patients. Patients are willing to discuss issues with you that probably were taboo in the past, but you need to be comfortable with addressing that. So you need to be comfortable with addressing sexual history, if they've had STDs, if they use drugs. And part of your approach is that you are equivalent with all the patients. So it doesn't matter if it's an 80-year-old person or a 22-year-old person. You need to address these issues. You may not address in as much detail, but you will address these things.
The group with the most rapidly increasing rate of AIDS, HIV/AIDS, is said to be the elderly now. And the Viagra and Cialis would all have changed the activity, nursing home issues, and so forth.
The sexual activity in elderly people, men don't buy condoms when they're beyond 65, but you need to have that discussion with them. Practice has changed also. The world is much smaller. People travel. Infectious diseases that were endemic in Asia are now present here. We have West Nile virus. We have Lyme disease throughout the country. Pertussis has reared its head again, so we need to address that. That had been nearly absent. Bed bugs are all over. Things scare people. News is out there, so patients are going to question. As far as the electronic record, which you'll become very used to very quickly in Cooper, it has been a huge improvement in the way we practice. The information throughout our health system with 400 physicians, 88 offices is readily available right at your fingertips. So we can see the notes from Dr. Patel, our hospitalist, in the office at any time. It's changed the way I've practiced. I don't have to carry charts home anymore, so I can go home and do my charting at home if I haven't completed it in the hospital. There's now an access for patients that we've turned on called My Cooper, where patients can access a portion of their medical chart directly through email. Now, email does not have to be used any longer where they direct it to your personal or work email. They can direct it into your electronic medical chart. So they can ask you questions, it can go into a pool in your office, our nurses can address that. But additionally, patients are able to access certain data from their chart. They can't access notes, but they can access the problem list, surgeries, vaccinations, medications, and certain results of testing that they've had. Can't access HIV testing. There are certain sensitive things that they still need to make a phone call.
Let me interject here a minute. This is very important. Yeah, today, patients demand the truth. I want you to contrast this with the following scene that I was witness to as an intern. We walked into the room, the retinue of the chief of medicine, and I was the intern, so I was the last in and the last out. The patient was the president of Pennsylvania Bell Telephone Company. In those days, Bell was everywhere, and there were statewide organizations. And he had tuberculosis. And he was being given medicine for tuberculosis. And he was coughing, and and it was. But as far as the patient knew, he had tuberculosis. So he pulls on, as I'm walking out, I'm being the last person, he pulls on the back of my coat, and he says, "Come here, Viner." He says, "I got to tell somebody that I know I have lung cancer, and I'm glad to go through this charade to make your chief of medicine comfortable, but somebody's got to know I'm not this stupid." And here's a guy who's running a big corporation and whatever, and we're treating him like a child. And that's the way it was in 1960. And all of this, and none of this could have been dreamt of in those days. The patients call in and get patients today have their results before I get them. I mean, you spoke about the anxiety, but the savvy patient knows how to get their results. Mm-hmm. They get on the internet and they get them. Sorry, I didn't mean to
that's
interrupt
fine.
you.
Very true. Just a few more comments. Paperwork is often overwhelming. The amount of prior authorizations that we have to get in the office to order a stress test and MRI often has to be justified both in your documentation and sometimes phone calls to the insurance companies. Often your staff can handle it, but not always. The medications, the direct-to-consumer advertising that patients now see on a regular basis, many of those medications are not covered. You have to go through 2, 3, 4 generics before companies will approve that. Patients don't want to hear that oftentimes, but you need to explain that to them. There was a study in 2005 in the Annals of Family Medicine regarding time constraints of physicians, and your average visit is about 15 minutes in the office, as Gloria said, for follow-up patients, but 55% of the time spent by physicians in the office was face-to-face with a patient. 14% was out of the room care of those patients, whether it be documentation, paperwork, calling other physicians, et cetera. 23% of your time in the office is spent on out of office evaluation and treatment of patients. It's phone calls, follow-up of test results, et cetera. So if you're a lawyer, you're getting paid for that. You are not getting paid for that. So you just need to understand that times have changed. unfortunately, and the amount of work you do that's not face-to-face is significant. And again, what Dr. Viner said I think is very important. It's my last point, is what has not changed is that you need to make a connection with the patient. You need to spend time with the patient or give them the perception you're spending time with the patient. You need to sit down, you need to take your time. Don't look rushed. You apologize when things don't go right. If there's a delay, you apologize. I always say the first patient every day is the only patient I don't apologize to because I'm always late. So the first thing I come in is, how long have I been waiting? Or how long have you been waiting? And I'm sorry. You need to be a regular person. You need to communicate with them. Talk about sports. You talk about their interests. You find out about your patient and you write that in their chart, what their interests are, what they do, what they like, where they graduated from. Doesn't matter, whatever interests them. And lastly, I would say that you need to admit your faults, admit your knowledge gaps, tell the patient you don't know about the diet pills. It's okay. You don't need to know everything, and you just you find out about it and you get back to them.
All right,
Can
well,
I just make one comment? You
Please.
mentioned Dr. Oz, and the man that I described to you that came in the jumpsuit to a doctor is actually Dr. Oz's father-in-law. He wasn't then, but he since has become Dr. Oz's father-in-law.
So a lot of what Dan says shows a lot of wisdom. You know, being a good doctor has more to do with using your common sense and your normal human interactive skills than any great knowledge. If you are able to relate to people, you will satisfy your patients. And as he says, they don't expect you to know everything, but they do expect you to be interactive, open, willing to learn, honest, and show that you care. All right, so we've talked about the doctor's perspective. Tell us about the nurse's perspective, Mary Jo.
Well, thank
I
you
know
for inviting me.
Probably the thing that has changed the most is the critical care situation and the sophistication of it. How does patient's evolution fit into that?
Well, thank you for inviting me. And I was listening to Dr. Hyman, and he said he was reviewing his list, and he noticed that it was negative. And I noticed that my list was negative, too. And I really needed to review that because it is very exciting, all the changes that are happening with communications in the families. But what has happened in the critical care area has really become an issue for the physician, a lot to do with timing and communication. And I'll give you some examples. Our physicians see 15 patients each in the ICU, and they are extremely critical. And they have to spend time with a lot of consultants and the interns, the residents, the fellows, the nursing students, the patients, and their families. When a physician walks into a room, the families expect them to know everything at the time they walk into the room. So years ago, you used to go in and do rounds, you do your examination, you tell the patient, we're going to do this, we're going to do that. And then you would come back the next day and tell them what happened with whatever tests, with the echo that we ordered or the blood work that we ordered. But today, they expect you to know everything. In ICU, we have about 3 or 4 consultants per patient. So when the physician walks into the room, the expectation from the family who is there constantly, they're there 24 hours a day, so you don't get the pleasure of walking in and meeting Mr. Jones, who's the patient, with Mrs. Jones. Sometimes it's the aunt, the cousin, the sister. There's always someone at the bedside who you have to re-explain everything to. They expect you to have the answers of what every consultant said over the last 24 hours. So you have to be extremely prepared when you go into the room. And I do think it's okay to say, I don't know. And I think it's very difficult for us as practitioners to say, I'm going to go look that up, or I don't really know right now, let me go find out. And I think you have to be open and honest that, the consultants were here, I'm here to examine you, I'm going to go back outside, I'm going to see what's going on. The other piece of that I really wanted to bring up was communication. It's very interesting now. Years ago, there was a control. The attending physician, the physician in charge, or the private practitioner who came in to care for the patient had total control of that patient. I believe physicians have lost control of their patients because consultants will come in and talk to the families and tell them their point of view and what they think tests should be done. And then when the attending comes in, they don't know that they've ordered these tests, and then they'll start asking the physicians what the results of these tests were, or maybe the attending doesn't even feel that test needs to be completed. So there's a lot of communication issues, and you don't have the time. Dr. Hyman was talking about 15 minutes per patient. If you can understand the amount of communication that is expected from the physician in the room, 15 minutes is just not even enough time. So I would really, if you ask me what the best thing that you could also learn on top of all of your medicine would be emotional control. Because I do agree with Dr. Viner's point too. You have to really be in total emotional control and accept. There are families that yell at physicians in the room. I've seen them be very rude and very obnoxious and have high demands and expectations. And I think the physician really controls that and needs to have emotional control. I had a couple of patient scenarios I thought I'd share with you. What was the difference of today as a yesterday? We've had 2 patients in our area frequently who were over 95 years old. They were unconscious and they were required a ventilator. And one of them had a bed sore. And the families absolutely refused to let us and the care, or even in the family meetings, discuss the patient's age. They wanted to take the patient home on a ventilator. So their expectation that they could take their mothers, actually they were both women, home on the ventilator, and for us to keep them alive. And it was very, very demanding on us and very difficult to keep these elderly people alive, infection-free, and get them to the point where we get them home on the ventilators with their trachs and the home care and setting all that up. It was very difficult because every time we would run into a roadblock, the next person I would be meeting was their lawyer. So I have had more family meetings with lawyers in them than I've ever had before, which I thought was really very interesting. We had a young man, he was 27 years old, and he was jet skiing down in the Jersey Shore. And he fell off of his jet ski, and his family took him immediately to a community hospital down the shore because he wrenched his knee. And while he was in the emergency room, he began to be very short of breath. And they got a little bit concerned, and they started doing some oxygen levels on him, and they were very low. And so they called Cooper because he got so short of breath that they actually had to put a ventilator on him. And they called us, and they air transported him to us. Turns out he had a severe, severe lung infection and ended up in shock. And we put him, he was only 27, he didn't have any insurance. We put him on the ventilator, we gave him all the antibiotics. He was in shock, we had to have a nurse at his bedside constantly. And the decision was to put him on a lung bypass machine. So we put him on a machine in the room that actually pumped the blood for him and oxygenated his blood. So this machine also comes with what we call a heart perfusionist. So that's the perfusionist that stays in the OR that runs the heart-lung machine during open heart surgery. So in the room was the perfusionist, the perfusion machine, 2 nurses that I had to have on them. There were several consultants. The mother, the father, and the brother never left the room. Every time the intensivist went into the room, he was bombarded by internet questions. They actually had on the phone a physician from Montana who used to take care of that machine. It's called an ECMO machine, who takes care of ECMO machines. And they would be on the phone to that physician from Montana saying, here, talk to this doctor because he thinks you shouldn't be doing this, or he thinks you shouldn't be doing that. They fought over anticoagulation of the patient constantly because one of the things from this machine is bleeding. So every time the nurse would give a medication to the patient, this brother would ask what it was and looked it up on the computer. It was really a nightmare. It's good on the fact that the families are educated, but they're very demanding, and I think that the expectation for the physician to take control of that is very difficult. It was really hard for me to get the physician to be comfortable going into the room. I've asked the family to leave several times, but that's not supported because there's a joint regulation that family member can stay with the patient 24 hours a day. So it's really...
Joint Commission supervises it sets standards for hospital care.
Right, they do set standards, and they come and they check, and you have to prove that you've allowed families at the bedside. So I think that also one of the things I wanted to agree with was the commercials on TV, the drugs that are on TV, the commercials for the drugs. Everybody sees those commercials, assumes they have that and they want it, and they're actually making appointments with the physicians to get those medications, which I think is really very interesting. And I just wanted to give you some past now and then kind of history. I was a new nurse, and we've already decided what year that was. Thank you very much. The first time that I got in trouble for being what I did was I started out on a monitored telemetry unit, and I actually got written up. I was disciplined for educating a patient, and that was back in 1980, because in those days you had to have a physician order to do education on a patient, and I just went in and started teaching the patient about his heart attack. And I just find it so interesting now how that's a massive change. That isn't really all that really long ago. Nurses are empowered to speak to patients, consultants speak to the patients, the families, the internet. The physician has to know everything everybody's been telling them, because as soon as they walk in the room, they're going to get bombarded with all the information that people have been telling them.
Excuse me, but I read an interesting paper recently about that demonstrated how much more effective patient education is when it's done jointly, or there's coordinated teaching
Right.
by both the nursing and the physician staff.
And I have to say the same exact thing, because they are writing everything down, and if you vary your words, then they really, really question you, and it's very, very interesting. I think one of the most important things is honesty with the patient. I've been a nurse long enough to see some devastating errors that were made just by human errors. And I've been with physicians who've actually sat down with the families. A nurse by accident went into the refrigerator, and instead of picking up an antibiotic called vancomycin, which is labeled and looked exactly like a bag of heparin, which is a blood thinner, actually ran the bag of heparin in a half an hour instead of running in the antibiotic. The patient bled to death and died. I was in that room with the family and the physician. The physician was very honest. It was a very easy mistake to make because of processes that we had put in place by putting those two meds together and whatever. That family never sued. And they had a great case, right? So I'm not saying that everything you do or don't do is all in communication, but I'm saying that you have to be open and honest with them, and actually sitting in the room and being very honest. This mistake happened. Years ago we didn't do it, but now when we do make errors, I go in the room with the physician and we tell them about the errors that were made. And the more communication, I think that's to your point, the more communication, there is less lawsuits. Absolutely, they are more litigious, as we do have lawyers in family meetings, but I think they're less litigious when there's a relationship. And I think that goes back to your point about finding out what they like and don't like. They really want a relationship.
Cooper has a mandate of disclosure philosophy now. You're supposed to tell the truth. You have to do it right and get advice about exactly, so everybody's on the same page. But increasingly across the country, it's being demonstrated that that approach lessens the medical legal issues rather than makes them worse. Okay, done? Okay. All right, so now we've heard from the three, and we'll let Mr. McMeekin wrap this up, because he has a totally different vantage point. He has a vantage point of someone who's operated a major health center, or health system.
Good morning, and it's a pleasure to be here. It's interesting also that you're the first class of this new medical school, and we're here talking about, what happened 50 years ago. Imagine, as you're sitting here 50 years from now, you'll get invited back to talk about all the things that weren't being done in 2062 or whenever 50 years is, that you didn't have available to you. I mean, it's just a fun world of medicine to be a part of, because the most constant thing about it is change. I thought it would be helpful, assuming that my memory serves me well enough, and I've got a good friend, Dr. Viner, who will correct me if it doesn't, to just go back and give you a sense of the changes in healthcare delivery in particular that have happened in the last 50 years as sort of a precursor for what you're going to go through and the changes that are going to happen. First off, as Dr. Viner said, we didn't have Medicare or Medicaid. We've all grown up in the last 50 years just knowing that there was that kind of a safety net out there. Prior to 1965, attending staff in hospitals and their residents and interns basically staffed free or part pay clinics in the hospital. You don't have that today. Today you have major ambulatory care centers, not necessarily in the hospital, all around. You've got a lot of doctors spending as much time on the road getting from one clinic or one office to the next as probably seeing patients. Get my glasses on here, I'll tell you a little more. No MRI, no CT, no PET scans, no gene therapy. You've heard everyone already comment there was no internet and no online measurement of hospitals and physicians in their practices that would then get published or be made available over the internet. Today, you can look up your doctor and find out how many cases he or she has done. You can check your hospital and see how they stack up or it stacks up against the Joint Commission standards. None of that was there. Good news for some of us was there was no real medical malpractice issue. Hospitals and doctors weren't sued as regularly as they are today, and that's become a major, major factor in the cost of healthcare, the defensive medicine as we talk about it. Patients were totally dependent on what their doctor, mostly, in fact, probably 99% being males, telling female patients what they should do or shouldn't do without necessarily having the kind of knowledge that today with a number of female physicians just have a better understanding. And again, as you've heard, and I know I've done it myself, we're supposed to be spending 15 minutes at best with each of the patient visits, and yet they come in with a whole stack of papers and questions about, well, what do you think about this drug, or do you think maybe I have this condition? How in the world can you have a relationship around such weighty issues when in fact you've got a time clock ticking? It is a challenge, and again, I guess the good news is it's a newer challenge for you than it was when Dr. Viner and I worked at Pennsylvania Hospital, where you did have more time. You didn't have the availability, or the patient didn't come in armed with the kind of questions. Physicians, if I'm correct, Dan and Ed, were in 1965, 75, 85, very much in private practice. I remember talking to my current physician, who's been my physician since 1984, who actually did his internship and residency at Pennsylvania Hospital back probably around 1984 or 85. He had just come to Crozier, and he said, "What do you think about doctors being paid?" And I said, "Well, I think it's going to come. First off, doctors are not all male anymore, and so you have female doctors and male doctors with different needs, different family obligations. It just seems like it's probably going to happen." And he said, "Well, I don't think it's going to happen with me. I'll talk to you later about 800 physicians, one of which is this physician, who are now fully salaried." I think that's a change that's going to continue to change. You've heard comments about doctors working in CVS and Walmart and all kind of other places. They're not there on private practice, but back in the 60s and 70s and 80s, very much so were doctors in private practice, and not even necessarily large groups. What we see today are groups of cardiologists numbering a couple hundred. I'm not sure what the real advantage is. I guess there's certainly advantage in aggregating almost anything in life, but that's a very different way to practice than the way the doctors that we tended to grow up with did. Out of the 2,100 physicians that are now part of the Kosher Keystone Health System, which you heard is a system in Delaware County of now 5 hospitals, somewhat organized around the larger medical center. But out of those 2,100 physicians, over 800 are fully salaried. Most of them primary care physicians, pediatricians, family practice. So I'm not counting the more traditional radiologists and pathologists, but plain old-fashioned good docs who have decided, one, the kind of practice they had, many of them out of an office in their house, without the ability to have all the access that they now could have through the internet, just decided this is no way to practice, and it would be better to be paid, and it would be better to have someone providing me the kind of tools that my patients and I need. Pretty obvious when you sit in a room with medical students that now over 50% of physicians of the future are going to be females. So us guys are going to have to wake up and recognize that we're not the king of the hill. But I think it's also going to impact on, as I said before, how physicians practice, particularly the newer female physicians who are often the family caregivers and have other obligations and other situations that aren't going to allow the kind of lifestyle the old man physician had, where you just work 60 or 70 hours a week. There probably were, back, I would say, probably up until 1985 or 1990, about 6,000 freestanding, meaning independent, hospitals, medical centers in the country. Today, there are less than 4,000, considerably less than 4,000, and many of them, much as was the case with the Kosher Keystone Health System, are now part of a larger system. Today's Inquirer talked about the potential merger of 2 already large Catholic health systems, Catholic Health East and Trinity, who are thinking of merging. And I think they're going to have something like 500 hospitals and medical centers as part of that. That's going to definitely change the intimacy that doctors and their hospitals traditionally have enjoyed. They're going to have a lot more colleagues than the typical smaller medical staff. So get used to having a crowd. And I guess the point that's been made, particularly by Ms. Hockman, not to diminish the importance of the clinical traditional side of medicine, but more and more of the almost psychological religion, compassion is being demanded of physicians. And I live in a little community in Philadelphia called Chestnut Hill, and they just opened a new hospital wing, and I thought it was interesting. 2 comments, one bearing on that matter and the other bearing on the role of the nurse. They talk about we are developing a culture of customer service where the focus is on care, courtesy, education, and respect. I don't mean it critically, and certainly not of Dr. Viner, who I have great respect for, but that was not the case in 1965, 1975, 1985. The doctor was the know-it-all, probably short on manners and courtesy, and very little time spent trying to understand the patient. A very interesting vignette, though, that I have to share, which does go back to 1967, I guess it was. This gentleman that Dr. Viner mentioned, Bob Cathcart, who was my boss, had me scheduled to go out to California for some kind of a meeting. I was still single, about to get married, new, in a sense, in the healthcare field, and had all the anxieties that any young person could have. And he said, before you go, I want you to get a physical. I want you to go see Dr. Bill Jensen, and just let him check you out. And I did, and I went through the usual routine. At the end of our, and it wasn't a 15-minute meeting, but at the end of that session, he said, I want to give you 5 prescriptions. And he wrote out the scripts. 2 of them were for who knows what. The other 3 were books. He said, I think if you read these books, it would be good for you. I think it would give you a better sense of where you are in life. And one of them is a very interesting one on sports. You'll enjoy that on the plane. And I thought, boy, that was a long time ago, and we're still talking about, but hopefully moving much more and really understanding the human side of medicine. It's probably your parents, if I'm guessing how young you are, the boomer generation, that has driven most of the biggest changes in the world we live in, from 24/7 banking to ATM machines to IRAs that are jointly sponsored by their employers, things that we never thought of back in the dark 1960s. And they're also the ones who have changed medicine. You look at your typical maternity suites, they're more like Four Seasons than what Dr. Viner and I can remember from Pennsylvania Hospital. We had wards of 32 people, one for men, one for women. That boomer generation said, this isn't working for me. And I think what's also true is medicine's really become more commercialized, more customer-focused. So waiting rooms, it's not the old magazine that's 3 years old and dog-eared. It's fairly current things. You heard, again, Ms. Hockman talk about the kind of technology that's available to patients. You don't have to wait. The electronic medical record, the same young physician that I met in 1984, throughout my now 30-some or some number of years as his patient, has gone from coming into the examining room or into his office, whatever you call it, with this huge stack of paper, and now comes in with a little, a little flat screen kind of thing. It's just interesting to see how much change has happened, and to know that as many things have happened in the 50 years that we're talking about, will also, I don't know what they will be, but there are also going to be those things in your life and in your career. And I guess my bottom line would be fasten your seatbelt, put a big smile on your face, and then wait till Rowan invites you back 50 years from now and be able to tell them how tough it was. But thank you, and good luck.
Thank you, Jack.
Dr.
Now-
Viner, I'm sorry
Please,
to interrupt.
yeah.
I just wondered, one of the things that I noticed also is with all of our critical care physicians, they all have dual degrees. They're all getting their MBAs too. So that is something very different.
Yeah.
A lot of the physicians are going to get certifications in not only critical care, but pulmonary and neuro, and so they're really always getting more and more too.
Let me say something that I think is very important generically here. There's lots of challenges. We focused on them because that's what we need to do. You don't focus so much on everything that's going well in life because it's going well, and by definition, it doesn't need attention. But while we're focusing on all of these issues and some negativity and so forth, it's very challenging, which is a positive thing. It's very exciting. It's very important to be part of change and evolve with it. It makes the juices run, and medicine's still fun. So let me ask Mr. McMeekin, Jack, our administration here, they worry a lot about their Press-Ganey score. What's a Press-Ganey score, and how does a hospital administrator, why do hospital administrators want to know about those kinds of things, and what do you do with the information?
Well, Press-Ganey is a national service that measures customer satisfaction, particularly in hospitals, and they do it by surveys and the like. And we tend to live by these surveys. The Joint Commission on the Accreditation of Hospitals now is reporting on quality issues, on readmission issues. Press-Ganey reports on patient satisfaction. Probably, is it Ann's list or something like that? Angie's list. I don't know if she is now recommending doctors and hospitals, but it wouldn't surprise me. And if she doesn't, someone else will be doing that. So we tend to live in a world where everyone has a microscope on them. And as you've heard others say, if you make a mistake, and mistakes are something that humans tend to make, it's not going to go undiscovered. It's not going to go unheard of. So you might just as well fess up to it right up in the front. And I think recognizing patients, both as physicians and as hospital administrators, as customers, is a whole different world than what many of us at this table grew up with.
Did you use this information to guide your decisions, inform your decisions about what programs to put in? And
Oh, absolutely, absolutely. And to the extent that they became, you could identify people, employees that were behind some of what was being criticized, you could and would take, action to correct that situation.
All right, well, in that regard, you got 800 salaried doctors, and you had 1,300 or what?
2,100.
100 that were not salaried. So you could dismiss the doctor that was repetitively criticized. You can't do that with the guys that use your hospital just as a referral base or to send patients into.
Yeah, well, I don't know that I speak for any large group of people. I think what I personally believe is that you don't dismiss doctors. Now, if they're really doing something egregious, you dismiss them before they go to jail. But the idea that they're like a pipe fitter or, I think physicians, for all of the criticism people might have, are still held very, very high. But what we could do is give them the tools that may have been the cause of some of their problem, get them to talk to the kind of doctors that they would like to be but aren't, and really more in a coaching way. I guess the reason for mentioning it in terms of 800 out of 2,100, I think we will see more people in medicine saying, this is not something I want to do by myself. And whether it's these large groups or as salaried physicians of a medical center or health system, they have available to them the kind of tools and coaching and sort of life conditions that most of us have.
I like your answer. Good. VJ?
I just want our students.
Yeah, that's next.
Question.
Yeah, that's
I
next.
just want to make one comment that is generally what I've heard. I call it the rules of engagement. I think in the last 50 years, the rules of engagement has changed. And a patient is living in a society where the society's rules of engagement has changed.
Right.
So you don't expect the patient to be just mimic what the doctor is, but I think the doctor has, and the rest of people have a responsibility to change with their own lost trust in us. And I think they have lost in trust because of some of the failure and finger pointing goes towards us as the people who are in healthcare. And the one about the structure of payment system and Medicare, if you look at the literature, the doctors and the healthcare system has become greedy. The Wall Street has become greedy, but equally, the healthcare people involved in the healthcare system, like the physicians, administrator, all has become greedy. And I think that has really has issues. So I think rules of engagement, trust, and the greediness. And I let one of the students want to comment and ask the kind of question.
Yeah, I think that obviously doctors are just a microcosm of the larger society. Doctors want better working conditions too. That's why they're getting salaried rather than maintaining their own offices. They want to go home at 5 o'clock and see their kids before they go to sleep and so on. And so it goes around and around. All right, let's open it up now. I said the last 45 minutes. We don't have that much time, but we want you guys to be interactive here with us. Can someone, questions? Yes.
What you were saying about greed and how doctors are spending less time with their patients and focus a lot on productivity. Do you think that has to do with the debt that medical school graduates are graduating with, and if that might affect their outlook or their focus?
Yeah, I think there's no question about that. And certainly it's got everything to do with why doctors aren't choosing primary care. And you can't make that decision in a totally naive and altruistic way. You just can't. And we've got to, that's a national problem we have to solve. Totally agree. Please.
Can I? Oh, okay, you go ahead.
Yeah,
No, I have something totally different. So
you go ahead.
My question is probably mostly directed to you, Dr. Hellman. So we were talking about how stigma about talking about cancer and like that has really changed over the years.
Right.
Why do you think that stigma towards talking about physical illness has changed at a much more rapid rate than mental illness, even though we do see it in the media and TV shows and commercials and overall?
I think because mental illness implies an impairment of the brain, and people are very uncomfortable about dealing with that. They're afraid that if they admit to that, it's going to affect their jobs, whether they will get a job in the first place and how they'll be perceived at their jobs. They're afraid of how other people will feel about them because it affects really their whole being in a different way than if somebody has cancer. It's such an open thing now that they'll talk about, but people don't talk about having schizophrenia in quite the same way because they're concerned about how other people will feel about it, and I don't think that stigma has been erased. Part of the problem is that mental illness has not been treated as comfortably by the medical profession. I'm not sure what the new regulations are, but I know it's been traditionally, if you have a mental illness, you get 30 days treatment in a facility, if there is a facility that will even admit you. So people aren't getting treated appropriately, and they aren't getting cured if there is a cure. I know someone right now, a very close friend, who is in jail because his mental illness, which is bipolar illness, just hasn't gotten treated. Even someone like Patty Duke, who had access to the very, very best of medical care, went undiagnosed for 16 years.
She's a famous actress of your parents' generation.
You can see her on Nick at Night or something, I don't know, but she had a show called The Patty Duke Show, and she's still on television occasionally. She had won many awards for her work, and she had bipolar illness. Did it help her work? Did it help make her more intense? Was it a gift? Was it a curse? Who knows? But she didn't get diagnosed for a very long time. And I think today that's the same thing. People will sort of still talk in whispers like they did about cancer. They'll talk in whispers about, oh, he's got a little mental problem. He's got a little something.
Yeah, and I think it's also got to do, with how much we know about how to fix it. You know, the cancer has become more openly discussed because there's a lot more treatment now than there was 50 years ago. And when there's medicines that we understand how they work and they can be specifically used and whatever, it won't be such a big deal to have a mental illness.
Well, the
Doc-
good news is how much longer
A lifespan we have. I mean, the reason we didn't talk about cancer is because most people died before they really knew it was cancer that killed them. Now we're dealing with Alzheimer's, we're dealing with dementias that, again, we're just cracking the beginning of
Yeah.
understanding how to treat.
And that's an important point. And one of the most fundamental ways, you'll see it's at the top of my list of how patients have changed, is that they're older. I mean, the average age of is longer, and new illnesses present, and that has a lot to do with the changes that we have to deal with.
But you know, with
I
mental
just wanted-
illness,
I'm
it
sorry.
affects people, it affects young people. I mean, a lot of mental illness emerges at your age. It shows up, bipolar illness doesn't show up until you're usually in your early 20s. You can look back and maybe see that there might have been precursors that you weren't aware of or you didn't associate. But unfortunately, mental illness can show itself early in life and affects people throughout their lives. But I think we're getting more open about that. As much as there is still a stigma attached to it, I think people do talk about it more than they once did, and I suspect that that's going to continue.
Mary Jo?
Speaking of mental illness, there is a severe shortage of mental illness beds in our area. And we have patients waiting at least 3 days in our ER waiting for crisis beds. You run into that a lot, Dr. Hyman?
I think even more egregious is the fact that we don't have enough mental health professionals, especially in this area. Insurances don't cover referrals to psychiatrists, clearly don't cover referrals to psychologists, and when they do, many of the psychiatrists don't accept insurance. It's pay out of pocket. So the poor underinsured people really don't have access. The other thing about mental health is that there still remains a stigma of weakness associated with it, and patients and people are perceived weak when they admit to this. And then the other thing is diagnosis is very difficult. It is still not, you can't draw a blood test and say they're depressed, even though our treatment is increasing serotonin in the brain by giving Zoloft, by giving an SSRI. We know how to treat it, we just don't know really how to diagnose it without addressing just a interview with the patient.
And when we get to the point that there's a blood test to diagnose manic depressive illness, there'll be a blood test or whatever, there'll be a medication, and it'll become like having pneumonia, but it's not there yet.
Not there. I did a story recently on a concept called Therapic, which is a website by that name, and it was developed by a filmmaker in California because he felt that when people need psychiatric help, they don't always know where to get it. They might get a list of names from their insurance companies, but they don't know one doctor from another or what the qualifications might be. And because there is still a stigma, they don't like to ask their friends for a referral. And the psychiatrist or psychologist who worked well for your friend Julie might not work well for you. So this is a service where psychologists, psychiatrists, social workers, mental health workers can make a video that is pared down. I watched them make it, a 30-minute video pared down to 2 minutes, and people can go into that site. It's organized geographically, so if you live in Camden, you can fill in your zip code, go into that site, and you can actually see 2 minutes of the therapists in Camden who are on this site, and maybe make a more intelligent choice because you can see body language, you can see facial expressions, you can hear what they have to say. Does their specialty match your needs? And I wondered as I was doing that story if that's something that might happen in other fields of medicine. And I'm curious about what you think. You think dermatologists might do this at some point? You think infectious diseases people might do it at some point? What do you guys think about that?
Dan, you want to
Nobody?
comment?
Well, certainly, we're seeing a lot more, as I mentioned, more commercialization of medicine. And I hope it doesn't lower what I honestly do believe is the social standing that physicians still enjoy, even though we have angry patients. Survey after survey compares doctors to lawyers. You're not lawyers. You're not down here in the bucket. You're still up here. So commercialization doesn't have to necessarily erode that, but it is a way of communicating and showing and being proactive about what you have to offer.
Well, it's not, I mean, you see infomercials, and I think that confuses a lot of people. You go on some television stations, there's one right here in New Jersey that does only infomercials. And if you get on the internet, you see a lot of, you think you're tuning in to some real new medical information, and then it turns out they're trying to sell you something.
And
So-
nobody supervises
And
that.
nobody supervises. It's the Wild
No-
West
no
out there.
editor that-
No, there's no editor that stands
This
between
young
you and
lady's
that.
been trying to ask a question for some time. Well, do both.
You can do both.
I think it's telling that I've been moving around a lot, and every time I move to a new place, I have to get a doctor or whatever. My first instinct is to go on Yelp and read
Yep.
reviews of the dentist or the doctor or whatever. And also, yes, Angie's List does reviews.
They do,
Pay them $25 more than what
right,
you pay them to review the plumber or whatever.
yeah.
Yeah, like I think, I don't know, from the patient's perspective, there's definitely way more resources.
Well, what it does is bring home the notion that you've heard a lot of talk about this morning and know before this morning, that the importance of humanizing yourself, the importance of being open.
Right.
Only go on if they really have, like, something hateful to say or they're really pissed about something.
Right.
So, it's hard to even distinguish, to filter through all that stuff too.
I was in a doctor's office in New York recently where the doctor asks his patients to sign a paper saying that they will not go on the internet and post comments about him. I don't know how many
That's your next
signatures he
contract.
gets or how many patients he loses, but I'd never seen that before.
Yeah, I've heard about that.
Have you
Yeah.
heard about that?
Okay, other questions? Please.
The practitioner side of the table, I know this is like the realities of medicine, and that's what the session is about. Is it worth it? I mean, we're studying for it, and we're like, oh, it's gonna be great, because after this we get to be doctors. But like, if you were doing it now, would you still, if you had to enter medicine, like where it is today, would you still do it, or would you do something else?
I would. I started my comments with saying that I think because of the nature of this topic, it's negative. And you have to address the negative, but the positives far outweigh the negatives. But the more you advance and the more technology and the more you know, the more questions are risen. And yes, it's definitely worth it. The issue about primary care that was brought up earlier, when I finished internal medicine residency, 50% of my class in 1994 went into primary care. It is now down to 10%. So the world has significantly changed, and I think it's not only the amount of varying work that we have to do, I think it's also the financial aspects, the amount of debt that you have. But it's clear that it's being recognized that change has to occur. Right now, one of the pushes is the Accountable Care Organization, which, if you haven't already addressed it, that'll be addressed shortly, I'm sure, this year in your curriculum. But accountable care is an idea that care will be given in a primary care setting not only by a physician, but it will also be distributed throughout a team. So there'll be nurses, nurse practitioners, counselors, social workers, et cetera. Right now, our average to busy doctors have a panel of about 3,500 patients, which means 3,500 people came through the office, individuals, over 2 years. So to do a true accountable care organization, a physician needs to have 1,000 patients because you can't manage it otherwise. So obviously something needs to change, but reimbursement needs to change. Right now we're paid, not Cooper physicians, we're salary, but physicians in private practice, what Jack said, is decreasing significantly. They're paid based on visits. So you see a patient, you get paid. That can't continue, reimbursement, if this accountable care organization is really going to advance and progress.
Yeah, there's a whole lot inherent in what he's just said. We've paid fee for service up till this point. So there's a built-in incentive, especially for specialists, to do more services, get more tests, have more visits and procedures and so forth. We got to do away with that. We got to pay doctors for managing patients' care. And whatever that patient needs, they get, and whatever they don't need, they don't get, and this will save money and make everybody much happier. Let me give an absolutely resounding yes, is it worth it? It is still the very best profession there is out there. Don't let anything anybody tells you dissuade you from that, but go into it with your eyes open, know what the problems are, learn how to prepare for them. It's like anything else in life. I'm 50 years in medicine plus, and there's nothing that I see out there that comes anywhere close. My father was had a wonderful business. I could have walked into it. I always knew I wanted to be a doctor. I was right, and I feel the same way about that now as I did 75 years ago when I made or 73 years ago. I was probably 4 when I made the decision to be a doctor.
So I really want to get to your comment because I do realize how negative it sounds from what we were saying, but in our lifetime, we have seen cures to disease. I started out as a cardiac nurse, and people came in and had heart attacks and died. And very few people have heart attacks today because when they get chest pain, if they get to an ER, they get into a cath lab and get rescue angioplasty and a drug called TPA. I was part of the study for TPA in our hospital. It was amazing. It's just amazing. We do hypothermia now. All those patients who used to pass out and die and come to the ER, but you'd cure their heart, but their heads would be gone. You know that Uncle George, it's always in the corner, a little weird. We don't have that anymore. I've actually seen cures. We now put valves in through legs. We get a catheter through the legs for elderly patients who can't really handle the surgery. They go in and they put an aortic valve in through a catheter in their legs. And the patient comes out without a respirator, without any issues, and goes home in 5 days, and now can walk and do all the things to have normal living. So in my lifetime, I've seen diseases being cured or really to the max, and that's what makes it worth it.
Good answer. Another question. I passed out some scenarios here. Let's just take a quick look at them together. First one, patient has lung cancer, learns about a new herbal treatment from an internet site, comes to your office and wants your advice. To get this, he would have to stay in Mexico and need to remortgage his home to get the therapy. This is a very real thing. There's all kind of alternative therapies out there that are totally uncontrolled, not allowed in the United States. They exist. This is a real case in my career. How do you advise this patient? What would you tell this patient? Ian? Pardon? Acapulco. Everybody agree with you? Well, it's not just to pay. He's going to remortgage his home. How is his kid's going to go to school? He's going to leave his wife destitute. Do you really, there's a lot of implications. But your answer is right. I mean, you counsel and you try to point out the obvious, and sometimes you'll succeed and sometimes you won't. But it is the patient's right in the end. And who knows what any of us would do in the end if they were in that circumstance. Please. I can't hear you, I'm sorry.
To me, this would be an equally challenging discussion to have, regardless of whether we're talking about, like, voodoo therapy in the Caribbean or, you know, doing extensive life support for a 95-year-old. I mean, it's tough because you don't want to bring money into the conversation with every patient you have, but at the same time, I have a really hard time understanding why we don't bring it up more for people who are essentially just turning their entire lives upside down to pay for something that they can't afford. And why they can't afford it is a larger issue in terms of support for therapies, whether they're alternative or totally mainstream. But, you know, I mean, I think it's just sort of a bigger issue that needs to be addressed over, and will hopefully be addressed during our early years of practice, I would hope.
I'm not sure that it's going to get addressed. It's a very touchy subject. Do you all remember the Shivo case? It almost split our country in two. It really, really did. And we
Well,
deal with that a lot, Dr.
It's
Lyman.
going to get addressed, it's going to have to be addressed. And, you know, the hospital is not obliged, and Jack comment on this, to give futile care. You know, once we get into a situation where care is futile, the hospital can legally not give it. Is that not right, Jack? And so that's going to happen more and more. I mean, I reacted just like you did about the two 95-year-old women. Nobody asked them, apparently, what it was feeling like to be on this damn respirator. And having spent 6 weeks of my life on a respirator, I can tell you it's not much fun. And I had many conscious thoughts about if I was 95 and somebody was trying to do this to me, I'd bang them on the head if I could.
You have to have the conversations, and the living wills, they're not always binding, so we do have to have a national conversation. There's a lot of research about the last 6 months or year of your life was where all your medical insurance is really being paid, and we do have to have these conversations.
And we have a selective issue in New Jersey. New Jersey is the most expensive state for end-of-life care. We spend more than twice as much taking care of people in the last year of life in New Jersey than we do in some states in the Middle West. And part of that's because those patients, for the most part, are being taken care of by primary care physicians. And in New Jersey, you got too many specialists, and every specialist wants to use all the tricks in his bag, and it costs a lot of money, and to no demonstrable benefit to the patient. Jack, you were trying to say something?
Nope.
No, sorry.
Continuing on with this, alternative treatments and urban therapies, I'm sure you all know that, you know, different cultures have different approaches to these things. They hold very near and dear to it. And how do you create a little paradigm shift? And how do you deal with those sort of almost emotional companions
Yeah.
to their cultural way?
Yeah. Well, I think that's a little bit, your point's very well taken. That's a little bit different. This was not a person who had a cultural orientation in this way, but that is an issue. And one of the things that my points about how patients have changed that we didn't talk about is the patients we're more and more diverse. Patients from all over the world live here now. And we need to be, and we spend a lot of time in residency program. VJ has been very much a leader in this, of trying to teach cultural sensitivity among our house staff and among our faculty, for that matter. Someone else had a question. Please.
For something like this, does the patient have, like, maybe initial diagnosis and then, like, it was sort of a gradual decline, or was it, like, he got a diagnosis and he had 3 months left of it, that's it? Because I feel like part of the problem is they get more desperate as their prognosis worsens.
No, that's exactly right. Whatever the point of time, it's the sense of desperation that drives them to do this kind of thing, and you have to do what you can to educate them and try to dissuade them from something you know is a total waste of money.
Because, like, what, do we have programs or initiatives that educate patients, like, right when they receive a diagnosis, to sort of almost prepare them for how
I tell every new patient that I see with cancer that they're going to get bombarded by stuff from the alternative therapy side of the coin, and would they please promise me they will come in and discuss it rather than just go off and do something before they, that isn't potentially good for them and so on. And patients do that. You do have to create the opportunity. And I think one of our most basic responsibilities to broaden that, we doctors need to create an atmosphere in our office and with our patients that allow and encourage all these newly informed people and the people who are highly desirous of asking questions. So we got to give them the sense that they can do this, that it's an environment in your office that not only permits but encourages this. You got to go with the flow, in other words.
Dr. Bonner, one thing that I think we've all seen is these commercials for Cancer Centers of America that are out there, and you can correct me if I'm wrong, but my understanding is that many of the treatments that they're espousing are not evidence-based. Intraoperative radiation therapy, and that they are advertising to people who are essentially incurable that we've seen. And are they giving hope to patients that are not appropriate? Is it appropriate? Is it worthwhile? I always look at these commercials and I'm not sure how to react to them.
Yeah, well, I got two responses. Number one, I think an oncologist, if he or she's careful in how they talk and so forth, can always give hope to their patient. I mean, the hope might be that they're not going to have pain in what is otherwise an inevitable dying process. But there's a way to create a sense of optimism in most patients. You're certainly going to live long enough to see your daughter's baby born or something, and you change your orientation to fit the situation, but there's always something positive. As far as Cancer Center Treatment for America, I think they do good enough care that it's not quackery. I mean, you can get good care there, I think. But they also do things, they're, quote, holistic in their approach, and they, for the patient that needs that kind of support and so forth, it's probably a benefit. Do they add to the total cost of how we take care of cancer by doing treatment that isn't evidence-based and very expensive? That's true, too. And they're obviously doing well because my son, who's in the construction management business, they're building new buildings and they're one of his best customers. So they're using the system to their benefit pretty well. So it's all of those things. Vijay.
I just want to say, can we wrap it up in the next 2 minutes? Because we have another session.
All right, well, you think about these scenarios that I gave you and there's no right answer to any of them, but think about them in your moment of leisure and your rare moment of leisure. Okay. I hope that you enjoyed this. I would like your honest feedback. This is an experiment for us. We've never done anything quite like this, either topic-wise or concept-wise. And so tell us whether you felt bored. I could see facial reactions that were positive and negative along the way. But be open about it. That's how we make it your next one of these better, and that's how we make your next class's experience better. I want to thank my co-panelists. All did a good job, and thank you for coming out of your otherwise busy lives to join us this morning.
Thank you. It was a pleasure.
Wish you good luck on your test.
Yeah.